Next, moving on with the agenda, I want to introduce and bring Dr. Alandro Jordan Villegas to the stage. He received his medical degree immunology training with honors from Universidad del Valle, Colombia, and completed his pediatric training at Miami's Children's Hospital. He then went on to complete an infectious disease fellowship at the University of Texas Southern Medical Center. Dr. Villegas.
And good morning. So we're going to share the presentation today with Dr. Dumas. So we're going to split the presentation in two. We're going to talk about clinical manifestation and diagnosis. So I took care of Jordan when he came. I was the pediatric infectious diseases that was consulted on his case. And I was really touched by the case. And every single day I still question myself, should we have done something different that day that would have changed what happened? And actually we started making some changes at Florida Hospital. So nowadays, when anybody comes, especially a child, to the emergency room, and any physician considers that the kid has meningitis and an LP needs to be done, the electronic medical system has an alert that asks the physician to ask for water exposure. So they have to go back to the room and say, have you been on water exposure, lake, pond, any kind of hot springs, anything that is fresh water? If the answer is yes, the system automatically orders a wet prep for Amoeba. So we don't have to ask the physician just to put the order for the test. Automatically goes to the lab. So when that CSF sample gets to the lab, they will run the test for the wet prep. So that is a way that we can take the bias out of the doctors probably and try to remind them to ask about the fresh water. And as well, we don't have to wait for a doctor or a nurse to put an order. It's going to be immediately going to the lab for the test to be done. And that is with the idea to try to catch, as much as cases as we can. So we don't have any financial conflict of interest. I want to do the presentation to be interactive, so I'm going to be starting, having the audience actually I'm going to ask questions, and I hope that some of you, participate. So this is a 9-year-old girl that presented in August with 4-day history of frontal headache, nausea, and vomiting. She was initially diagnosed by the PCP with a viral syndrome. She was in at the office, said, you look fine, some headaches, some vomiting, she probably has a virus, the summer virus, and just go home and get some hydration and fluids. Over the next 24 hours, the frontal headache increased. She was somnolence, she has some MSEs. On the 8th of the symptoms, she developed intermittent hallucination, increased agitation, and then she was rushed to the ED. When they got to the ED, she was more lethargic with intermittent hallucinations. She was febrile when she was examined. She did have some meningeal signs, but they were not really kind of strong meningeal signs to call it this is a bacterial meningitis. And when we said that, we just look for kind of a stiffness of the neck, really bad headache, and things like that. But she was having agitation and some altered mental state that was actually intermittent. There was sometimes that she was completely herself. Past medical history was really unremarkable. A little bit of asthma, well controlled, no surgeries, family history, some diabetes and hypertension. Immunizations were up to date. She was living, with her parents, 2 siblings. They didn't have any pets. They didn't, report any travel at that point or any sick contacts. And then, obviously, because of the symptoms of the meningitis, she was started on vancomycin and ceftriaxone. That is the typical medication that we usually do for bacterial meningitis at this age. So what question do you want to ask if you have a patient like this one? Comes to the ED, has some altered mental status, some hallucinations. You examine the patient and you may think that has meningitis based on the history in your exam, but they are not the typical that you will say this is for sure meningitis. What other things you may want to ask to that patient or that family that may try to help you decide what other things you have to do? Anyone? What activities they do, what else? Freshwater exposure. So always exposure history, and that's something that we usually, do in consultation, especially pediatric infectious diseases. We always ask for sick contacts, anybody in the house with runny nose, congestion, cough, vomiting, recent illnesses, if they have been sick, weeks prior, any kind of substance exposure or abuse, any travel history, and where actually they have gone, out of states, in the same countries, different city, animal contact, insect bites, including tick bites, and obviously water exposure. In the water exposure, what do you actually want to ask for water exposure? There are many types of water exposure that you can have. So any ideas? Can you try to delineate more? What do you want to ask for those? Fresh water, okay. So fresh water, there are many sources for fresh water. You have lakes, you have rivers, you have ponds, you have hot springs. Unchlorinated sources as well. So you have pools, you have wells, Everybody knows a few years ago there was an adult actually that got the disease secondary to one of the Nelly pots. When they got to the house, they realized that he was using well water from his house. That was the water that he was drinking, and he used the well water for the Nelly pot, and he got the disease. There are several reports, not in the United States, but in other countries, of sprinkles as well. And it's the water that is on the sprinkle that has been sitting there for a long time in the summer. As soon as they turn the sprinkle out, that water actually can carry the amoeba as well. So we know when you have these kids that are on the backyard just playing with the sprinkle, and if the sprinkle just hit the nose, they're at risk as well. Especially if the house in the water is the well water where it's coming from. So sprinkles are what is one of the things, and we never ask for a sprinkle. So I have never asked myself, hey, by the way, have your kid been on the playground playing with the sprinkles? Never asked. I have to say after Jordan, when my kids go outside to play with the sprinkles, I always turn the water for a long time before they go, just to try to watch that. But I never thought about that before this case and before I started reading more about the case. So the physical exam, not febrile, at the time that she was seen, but she was hypothermic with a temperature of 95.5. The vital signs were within normal limits for her age. Nothing that will strike in the vital sign that something was going on. She was agitated, but she did have some episodes of cooperation with the exam. She had a little bit of pain on flexion, but kind of not the typical stiffness you will see with your phloem-bond bacterial meningitis. And the rest of the exam was completely normal. Even the neuro exam, besides the intermittent agitation and hallucination, she was able to answer some commands. The cranial nerve was normal. She didn't have any paresthesia or hemiplegia, nothing like that out of the ordinary. So the evaluation was done. The typical thing that an emergency room or any physician will do is get your cultures, blood culture, urine culture. We do a spinal tap to look at the CSF. And then the patient didn't look really bad to go to the ICU, so she was admitted to the floor with the diagnosis of meningoencephalitis, and it's because she was having some altered mental status. That's what the encephalitis kind of comes into the diagnosis. So these were the labs, a little bit of leukocytosis. So the white cell count was a little bit elevated to 18,000. The LFTs were within normal limits. The sodium was a little bit low, but it's still within the normal. So the thing that was really abnormal, obviously, is your CSF. Opening pressure was really high, meaning that you did have a lot of intracranial pressure on that CSF. The white cell count was elevated to 3,100. Glucose was slightly low, but not completely, low, and the protein was really high. So that an abnormal CSF, that we'll call it meningitis, and usually with an increase in the white cell count on that CSF, we'll call it bacterial meningitis. That will be the main thing that we'll think in this case. Viral meningitis shouldn't be as common, although there are some reports that weird viruses, or sometimes you can see as high as white cell count of viral, but the majority of the cases will be bacterial meningitis. So you have a kid like this one. What else would you like to order besides your cultures? If you have the history of freshwater exposure, what specific tests do you would you like to run? Exactly. So that's the wet prep. Anything else? So if obviously the kid, was started on vancomycin and acyclovir, typical medication that we'll do for a patient that is come with meningoencephalitis. So wet prep, and that's what the sample gets taken to the lab. It gets centrifuged, so it gets sediment, gets heated up, so they can see the amoeba moving. And I have to say, when you read the literature, the majority of the cases of amoeba encephalitis are diagnosed with the regular CSF. So when the CSF get to the lab and they look at the cell count, in the majority of the cases they're able to see the amoeba moving, and that's what the diagnosis is made. Without you have to order the wet prep. It was not the case for Jordan. They look at the CSF on the smear, they didn't see any amoeba moving. They said, it just looked like some white cell counts there, but they didn't see it. So in that case, we didn't order at the beginning, the wet prep would have helpful because they will hit the sample and spend more time looking at the amoeba. And unfortunately, we didn't send the test. The gram stain, they can look at trophozoites on the gram stain. Is not easy to look. They have to know that they are looking for to be able to look for those. There is amoeba culture that takes a long time, and obviously we have PCR available. Unfortunately, we don't have it in the hospital. It has to be done through the CDC. But there are kind of the tests that you can do if you want to diagnose amoeba. You're suspecting a case of amoeba encephalitis. Any questions at this point before we move to Dr. Dumas? The typical medication that will you do, like vancomycin, ceftriaxone, and acyclovir, it doesn't impact the test. So if you have a patient that comes with, diagnosis of meningitis, you have to rush antibiotics even sometime before you do the LP. But those antibiotics are not going to affect your test for amoeba, so you can do it. So you have a patient that comes with meningitis, you don't have time to do the LP. The recommendation is to start antibiotics right away. So let's say you have the patient, you don't have the sedation ready, you can do the LP, just start your regular vancomycin and ceftriaxone. That's the typical thing, that's the recommendation. After that, you can do your LP and you can send the test. Those antibiotics are not gonna modify the amoeba testing at all, different from the bacterial testing. There are some times that one single dose of medication will bring your bacterial culture negative, but it's not gonna change your amoeba testing. So as soon as you do the LP, if you have the suspicion, just send the sample. Well, and that's going to be a really good presentation for Dr. Lyman. He's going to talk about the treatment, but then it changes completely the approach that you have to do. The patient has to be transferred to the ICU, and he's going to talk about the protocol that, where the kid survives. So different medications that they have to use, intrathecal medications and IV medications as well. So it changes completely.
After Jordan was diagnosed, I think Dr. Cope will actually touch on the CDC reaching out to the Ministry of Health in Costa Rica. From what we understand, the Ministry of Health said that it was very rare, and they made the resort put up a warning sign. I don't believe that there's been anything done to chlorinate the water. Yes, if you go out to the Tico Times, you can read that news article. And they stated the Ministry of Health found it positive in 6 of the 23 hot springs. But they said they didn't see any need to chlorinate the water because it's very rare.
Thank you for the question. A little more work was done to try to connect the Department of Health, CDC, with Costa Rica Ministry of Health in order for messaging. And so I believe some of that is still ongoing.